Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Dr. Nicholas Gallagher on high-dose buprenorphine induction, the who, what, where, when, why, and how. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar are their own and do not represent the position of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentation for questions and answers, so please hold your questions until that time, or you can place them in the chat feature in Zoom. Slides and materials from today's webinar will be sent out in the follow-up email. And now I'd like to give a quick introduction to our speaker today. Dr. Nicholas Gallagher is a board-certified fellowship-trained addiction medicine specialist who treats patients with substance use disorders at Maine General Addiction Medicine, where he also serves as the medical director. Before joining Maine General Medical Center's active staff, Dr. Gallagher practiced emergency medicine as an emergency medicine physician at Kent Hospital in Warwick, Rhode Island. And with that, I will pass it off to Dr. Gallagher for our presentation. Thank you all for being here today.
Thank you, everyone. It's really nice to be here and happy to be here to talk about this topic in particular. First and foremost, Bethany did mention that I don't have any financial conflicts here. So what we'll cover today is, like the title says, I'm kind of breaking it down into a few different categories. So we're going to talk about what are high dose inductions and why would you consider using them. I know most of us here understand the mechanism of action and the pharmacology of buprenorphine, but I'd like to speak a little on some specifics as they relate to high dose induction. So we'll do that, and then we'll talk a little bit about precipitated withdrawal and the properties of displacement and mu-opioid receptor agonism that kind of go along with precipitated withdrawal. We'll talk about who should be considered for this, where you can do it, when you can do it, and also how. We'll do I'll walk you guys through a step-by-step method, and then also at the end, I've got a few cases that I'd like to talk about. So with that being said, we'll get started here. So what are high-dose inductions? They're a method of rapid introduction of buprenorphine at doses that are typically higher than the standard methods, which, you know, the standard or the low dose methods that have been used for quite some time. So a little different in that aspect. It's relatively novel in that there's been some data coming out recently about its effectiveness. Typically, the starting doses are maintenance doses, 16 to 24, sometimes a little bit higher to start with. And there's not really any need for extended abstinence period or significant pretreatment withdrawal, which is helpful in a lot of cases. So first and foremost, I just wanted to let everyone know that this is one of the three methods that is listed by ASAM as things to consider when introducing buprenorphine on patients. And the other two methods I mentioned previously, standard and low dose, are also mentioned there. So this is something that ASAM has promoted. So why high dose induction? So everyone who does this work knows that inductions have become much more difficult these days with the presence of fentanyl in the drug supply. You know, fentanyl has really changed a lot of things due to its potency. Most patients are experiencing severe, prolonged withdrawal symptoms, intense cravings, and the substance is extremely dangerous. So there is a sense of urgency to get patients on this medication in a safe and effective and relatively quick fashion. So this method does do that. And in addition, you know, we're always trying to provide patient-centered care, individualized plans of care, and so adding additional methods to our toolbox is helpful to respond to all the situations that come to us. So why high dose inductions? Well, it's a much faster introduction to buprenorphine as opposed to some of the low dose or standard method where there needs to be typically some longer period of withdrawal and then it's a slow introduction. So this is much quicker. And as I said, there's for the most part, no need for a significant withdrawal period. And it can be used in multiple different settings, the inpatient setting, outpatient setting, the emergency department, and can be done from home. And I've done these in all the settings. So all the settings I listed. So I will speak about some of that experience. And my favorite part about this is that it produces rapid and widespread mu opioid receptor occupation, which is very important. We'll talk about that moving forward here. So in addition, why high dose inductions? Well, I pulled some of the more recent articles on low dose inductions, and there's a lot of inconsistencies here when you look at some of these studies in terms of they have a lot of relatively low number of patients, and the dosing regimens are kind of all over the place. So there isn't a lot of standardization here. In addition to that, looking at the withdrawal rates, they're higher than what has been shown recently with high dose inductions, but pretty high. I mean, 58.3% with the Bernice method in this one study here in 2021. But there's a number of other studies. These are just a few that I pulled, but the withdrawal numbers are relatively high, and there's a lot of inconsistency. So it's hard to figure out exactly what to do and how to do this. So this is another kind of issue that we face is how do we do this? And even looking at the studies that have come out recently, it's not always that clear, nor does it tend to produce great results. So I'd like to start by talking about some important properties of buprenorphine as they relate to high dose induction. So first and foremost, we all know buprenorphine is a partial agonist of the mu opioid receptor. And now the graph here on the right shows comparison of the ability of buprenorphine and its metabolite to stimulate mu opioid receptors as compared to full agonist opioid. So if we're saying that a full agonist opioid has a potential to fully stimulate that system, buprenorphine on average is going to be about 38% as effective as full agonist opioids at stimulating the mu opioid receptors. And norbuprenorphine, its metabolite at about 81%. So if you average the two, you could say a reasonable number would be about 60% as effective at mu opioid receptor activation or stimulation as compared to full agonist opioids. And that's going to be important here. So one of the reasons why it's important is because of when we're considering giving people high doses of this medication, well, it's been shown in a number of studies, and I'm sure anecdotally for a lot of people here, it's incredibly safe. I mean, it has been shown to have a ceiling effect against respiratory depression. So, and one of the reasons why is that 60% mu opioid receptor stimulation is far below the sedation threshold for patients that are using full agonist opioids regularly, especially fentanyl. So you're typically not even going to be able to reach that overdose threshold if you're talking about patients who are using 1, 2, 3 grams of fentanyl a day. They're not going to get a level of intoxication or mu opioid receptor stimulation that's going to cause significant central nervous system depression. So it's an incredibly safe medication for patients who have opioid use disorder, who are using especially high potency synthetic opioids such as fentanyl. So here's a study that was done recently looking at the ceiling effect. And as you can see here, the line that's kind of the second from the top there, that is represents breaths per minute. So these are patients that were given, and you can see the buprenorphine dose on the bottom here and the breaths per minute on the left side of the graph. As you can see, when patients are given buprenorphine, after about 2 to 4 milligrams, they can get a little bit of a decrease in breaths per minute. Initially, the patients were shown to have that, but it levels off after about 4 milligrams. And then the line on the top is the O2 saturation, which remains relatively stable all the way up to 32 milligrams, which you can see all the way on the right-hand side. An interesting part of the study too was the quote-unquote good effects, which represent sort of subjective feelings of intoxication. So after about 2 milligrams or so, you see it leveling off. So patients are not really reporting much in terms of intoxication or quote-unquote good effects after 2 milligrams. But the important piece here is that the breaths per minute are not really all that impacted. And the O2 saturation remains stable in these patients, even up to 32 milligrams. This is a little bit of an older study, as you can tell by the title, effects of high dose IV buprenorphine in experienced opioid abusers. So this is a 2004 study, and it basically examined the effects of misuse of buprenorphine via intravenous injection. And they had patients inject doses that would be normally taken sublingually up to 12 to 16 milligrams. And they did not find any significant respiratory events in patients who were using intravenous doses of buprenorphine up to 12 to 16 milligrams. And interestingly enough, this is about 53 times the recommended therapeutic analgesic dose of intravenous buprenorphine formulation, which the average dose is about 0.3 milligrams IV for analgesia. So even patients with opioid use disorder who were taking up to 53 times that amount via intravenous injection did not show any signs of respiratory depression. So moving on to the mu-opioid receptor affinity properties of buprenorphine. So I like to discuss this in two ways, the attraction of the molecule and the grip of the molecule to the mu-opioid receptor. Buprenorphine has a much higher attraction to the receptor than other full agonist opioids. In fact, higher than all other commonly used full agonist opioids, and it has an incredibly strong grip on the receptor. So once it binds, it's very hard for other opioids to displace it. So you have buprenorphine will compete for the mu-opioid receptor, and it will displace other full agonist opioids. In addition, because of its strong grip on the receptor, it's very difficult for other full agonists to bind. So these are important things to consider when you're talking about giving buprenorphine and sort of how it works, and especially at high doses, and how it interacts with things such as fentanyl in the patients that we're giving this medication to. So this is a graph showing the affinity, receptor binding affinity of buprenorphine. The Ki is the lower the Ki, the higher the affinity. So as you can see on the left here, buprenorphine, as compared to all these other opioids, has a higher binding affinity, and by a pretty decent amount as compared to fentanyl. It's got about a 6.14 times greater affinity for the mu-opioid receptor as compared to fentanyl. Interesting fact, this is about where naloxone sits. So buprenorphine has a higher affinity than even naloxone. And this also sort of explains why sometimes it's hard for naloxone to bring people who have overdosed on fentanyl back. The affinity is pretty close between naloxone and fentanyl. The other interesting piece of this is one of the reasons why I like to use hydromorphone for patients that are on buprenorphine. If, say, they're in the hospital and they need pain relief, hydromorphone is a good choice because it's the opioid that we have commonly used that has the closest mu receptor affinity to buprenorphine. So if you're trying to treat pain on top of buprenorphine treatment, hydromorphone is a good choice here. So this is my weird picture of a brain that looks like a kid drew it. But the green squares there are representative of mu-opioid receptors, and we're going to look at mu-opioid receptor occupancy by buprenorphine dose. So if you give 2 milligrams of buprenorphine to somebody, you're going to occupy about 40% of their mu-opioid receptors. If you give somebody 16 milligrams, you're going to occupy about 88%, which is, pretty good amount of mu-opioid receptor occupancy, which can kind of start to explain why, at least for me, that's a dose where I start to really see it being effective for patients who are struggling with fentanyl use disorder. And at 32 milligrams, we're looking at about 96% of those receptors being bound up by buprenorphine. This particular graph here is showing the percent mu-opioid receptor availability as compared to sublingual buprenorphine dose. So as you can see, when patients are given 32 milligrams of buprenorphine, almost all of their mu receptors are bound up, and there's really nothing available for many other opioids to bind. And then as compared to 16, there is a significant difference there between the binding availability or the mu opioid receptor availability there even between 16 and 32 milligrams. And so the reason why I'm harping on all this is because when we start talking about giving higher doses, all of this becomes important because we're trying to consider the balance between buprenorphine's ability to displace other opiates and also its ability to provide adequate mu opioid receptor stimulation, but also an important piece is protection against overdose. So as you can see here at a dose of about 32 milligrams, there's really not a lot of opioid receptors left for anything else to bind to. And this is 4 hours post buprenorphine. So the effects do last for quite some time. A couple of other quick studies here that are interesting. This study was done with the dosing isn't really equivalent to what we talk about. It was a study that was done with rat brains and applying fentanyl and buprenorphine to the mu opioid receptors in a lab environment. But the important piece of this on the left here is what I wanted to display was that there is a dose-dependent relationship between the amount of buprenorphine that somebody is given and the percent fentanyl dissociation. So how much of the fentanyl is still remaining on those receptors by dose. And as you can see, the top line at 48%, that's 1 nanomole per liter. But as you double the dose, you get increased amount of fentanyl dissociation from those receptors. And then at 3 times that initial dose, you get a lot more dissociation of fentanyl. So the higher the dose, the more dissociation that you're going to get of fentanyl from those receptors. On the right-hand side here, this is an interesting part of the study as well that shows what happens when you give buprenorphine and fentanyl at the same time versus pre-incubating the membranes, giving buprenorphine 45 minutes before introducing fentanyl. So as you can see, when it's given in a dose of 0.5 nanomoles per liter, you have a certain amount of fentanyl that is still bound to those receptors. But as you increase the dose across to 1 nanomole per liter, you're getting increased dissociation and displacement down to significantly lower at 2 nanomoles per liter. So dose-dependent relationship here, but it's interesting to note that the difference between the control, which is bup and fentanyl added simultaneously, versus the difference when when buprenorphine is applied to the receptors prior to fentanyl, you get much less binding and more displacement. So when patients are given buprenorphine prior to being introduced to fentanyl or having fentanyl introduced into their system, there's much less ability for fentanyl to actually bind to receptors. So this translates into helping with the prevention of overdose or the protection against overdose, providing an element of protection. So these are all important considerations when we're thinking about how we're getting buprenorphine into somebody's system, how much we're giving them, and also the safety of that. So these are just important considerations. Like I said, the dosing isn't relevant to sort of what we talk about, but it's just showing the dose-dependent relationships between these things. So in terms of the interesting pharmacologic properties of buprenorphine, so a quick summary. So as I mentioned, bup is a partial agonist and with about 60% ability as compared to other full agonist opioids to provide mu opioid receptor stimulation. Buprenorphine has a very high mu opioid receptor affinity, as we saw in the graph, higher than all other commonly used opioids that were compared. It has a very high attraction to the receptors and a very strong grip on those receptors. So it readily displaces other opioids that are there, and it makes it difficult for opioids to bind to the mu opioid receptors that are occupied by buprenorphine. So there's a direct relationship between the buprenorphine dose and the fentanyl displacement from the mu opioid receptors. So the higher the dose, the greater total percent displacement that you're going to get. And there's an inverse relationship between the mu opioid receptor availability and the buprenorphine dose. So the higher the buprenorphine dose, the lower the mu opioid receptor availability for other full agonist opioids to bind to. And so pretreatment with buprenorphine increases the percent fentanyl displacement from those receptors. So this is really important when we're considering possible adverse effects of any form of induction, whether it be the low dose standard method or the high dose method. So I'm sure all of us have had situations where we've given lower doses of buprenorphine in an attempt to slowly add it onto the receptors, and it can cause withdrawal, and I've seen it. I'm sure everyone has seen it. So I want to be clear that I'm not in any way saying that there's no risk of precipitated withdrawal with high dose induction, and we'll talk about the numbers a little bit. But the question here is, what's the safest method? So in my eyes, if I would much rather have somebody given 16 to 24 milligrams initially of buprenorphine, and if there is some precipitated withdrawal and they do go and use full agonist opioids, they're going to be much safer than if somebody is given 1 milligram, 2 milligrams, 8 milligrams, and then goes through precipitated withdrawal and then goes to use. So in terms of the properties of buprenorphine, its ability to bind up those receptors and its ability to provide protection against overdose, it seems safer in this aspect, because even if there is some precipitated withdrawal, then you are initially providing widespread occupation of those receptors, thereby providing less room for additional full agonist opioids to bind if there is some precipitated withdrawal. So we're going to talk a little bit about precipitated withdrawal. And so the way that I like to view this is that because of the properties of buprenorphine that we discussed, there's a significant imbalance between buprenorphine's ability to displace opioids and buprenorphine's ability to provide mu opioid receptor agonism. So buprenorphine at low doses even at low doses, as I mentioned, at 2 milligrams, you're looking at 40% mu opioid receptor occupancy. So even low doses like that, you're still going to get a decent amount of displacement of full agonist opioids, which can cause withdrawal, but we're not going to get adequate mu opioid receptor agonism to deal with the withdrawal symptoms at doses of 2, 8 milligrams. So we need to figure out a way to strike a balance here between these properties of buprenorphine, which is why this is an important consideration when you're trying to figure out how to start buprenorphine on somebody. So this graph here on the left-hand side, what you're going to see is the dosing is on the bottom, and the risk of precipitated withdrawal goes up as you go up there on the left-hand side. So on the left-hand side here, at low doses of 0.5, 1 milligram, you're not getting a lot of displacement. I mean, you get some, but not a significant amount at 0.5 or even maybe 1 milligram. You can cause withdrawal, but lower risk at those doses, and depending on length of time since last use and et cetera. But you're not getting a lot of displacement or agonism at all at that dosing level. But as you move into the middle here, it's sort of like the danger zone. As you get up to 2+ milligrams, really up to 16 milligrams, you're getting the displacement far outweighs the agonism, especially in patients who are dependent on high potency synthetic opioids. So this is in this area right here, you're going to get a significant amount of displacement without really any adequate agonism to control the symptoms. And this is where precipitated withdrawal comes into play. So on the right-hand side here, we're talking 16 to 24 milligrams. So you're going to get a large amount of displacement, but you're also going to get a decent amount of mu opioid receptor agonism. And the important thing to recognize here is that 16, 24 milligrams, those are pretty common maintenance doses. So we know that these doses provide adequate mu opioid receptor agonism and are effective at providing symptom control in most patients. So we see that every day when we treat people, who are in maintenance treatment. So here you're going to get a lot of displacement, but you're also getting a lot of a good amount of agonism that is going to help to deal with the withdrawal symptoms should they arise. And a lot of times with the high dose inductions, you don't even really see much withdrawal at all because the bupe will displace, but you provided an adequate dose to deal with the withdrawal symptoms. So I'm sure a lot of you saw this study, but this is just to highlight. We know through anecdotal experience, we know through a lot of the studies out these days that that doses of 16 to 24 milligrams are really effective. Actually, a lot are more leaning towards higher end, 24, sometimes 32. And this was a pretty good study that was done fairly recently in 2023, showing that even patients, when they compare 16 milligrams to 24 milligrams, patients do a lot better on the 24 milligrams and stay in treatment for longer, have better symptom control. So this is just here to highlight the evidence behind some of these higher doses that we're using for maintenance treatment. And really the trick here is to get people started on a maintenance dose relatively quickly and displace the fentanyl, displace the other opioids, whatever they may be, and provide adequate symptom control via a maintenance dose that is essentially given to them at one time. So that's sort of the basis of how this works. So when we're talking about high dose inductions, like we need to discuss who should be considered for these. And so obviously at any point in time, we're talking about patients with opioid use disorder who want maintenance treatment. That's pretty obvious. So whenever I'm meeting a new patient or assessing a new patient, if there's somebody who wants buprenorphine maintenance treatment, then this is always going to be a consideration for me. I've found it to be particularly useful in patients that are using high potency synthetic opioids. It's particularly beneficial when you're talking to patients who are previously unable or have been unable to abstain from opioid use for extended periods of time. So for the other methods, typically like the standard method, really typically you want a good amount of time to be in moderate withdrawal prior to starting buprenorphine induction. And I've just met so many patients that are unable to get there. They just can't do it. And they go a day, maybe two, and the withdrawal starts to become severe enough that that they return to use. But I've also seen patients who present in kind of moderate withdrawal and look like they're ready, and that you give them a lower dose of buprenorphine and it gets worse. So even patients, it's kind of tricky with that. Even the patients that 5, 6, 7 years ago, when they had a COW score, and they were in moderate withdrawal, we could start low dose when it was primarily heroin or opioid pain medication. It was much easier to get people started when they were in moderate withdrawal. And nowadays, personally, I'm seeing a lot of patients who are in that space, but because of the fentanyl, if you give them a low dose of buprenorphine, that withdrawal gets worse and then often leads to return to use. So, and also, I'm sure everyone has met plenty of patients who are legitimately scared to get induced on buprenorphine because of prior withdrawal. So with patients who have tried other methods and have just been unsuccessful, introducing this as an additional option has been really helpful and has been provided some comfort and some hope for some people, because there's just a lot of people who have tried this many times and it just doesn't work for them. So who should be considered for this? So I like to say this as sort of pre-treatment considerations that my checklist that I kind of go through. So, and I phrase this as a relative risk assessment, because what I'm always thinking about is the risk of what somebody is already doing versus the risk of what we're going to do to try to intervene. And typically, obviously not always, but in this particular field and with the status of the potency of the drug supply these days, typically most of what we're going to do is much less risky than what is happening without us. So that's why I call it relative risk assessment. So I always want to get a good history. What type of substance are they using? What amount? And what's the method of administration? intravenous, inhaled, intranasal. Also overdose history, just a good solid history of their prior use, which allows me to kind of, like I said, get a relative risk assessment. And then I always like to know about their treatment history. So have they been on buprenorphine before? If so, what was the dose? What was their response? Was it effective? And also, I always ask how they've been initiated in the past. Uh, Hopefully successfully they've been, and they can give you some data on that. But also it's important to understand if there's been times in the past where they haven't been successful, and kind of exploring that and using this as an additional option, especially if someone's really apprehensive to consider starting buprenorphine. So the other kind of considerations that I walk through is, if we're considering doing this at home, it's what's their personal situation. So what's their living situation? Are they living at home? Are they do they have support? Are they versus somebody who's unhoused, without any support? What about transportation, communication? Because there's always a risk of adverse side effects. So if you're going to plan to do this outside of or unsupervised per se, you always want to know sort of what the social situation is like. And external supports are really important, especially if you're considering doing this at home. Is there somebody there that can help them, that can watch over them, that can take them to the emergency department if needed? All those things are really important with considering this. I would argue that it's as important as any other method, because every other method has a risk of causing precipitated withdrawal as well. So I don't think this one's any different in that sense. And then I like to also get a good medical history, and these all help me decide like what's the best setting to do this. If somebody has a lot of comorbid medical problems, it may be safer to do this in a supervised setting. And then if, like I said, if somebody has support versus not, those are all important considerations to make prior to figuring out what method you're going to use and then how you're going to do it. So we'll talk a little bit about relative contraindications. I would say, if somebody's had a prior adverse reaction to buprenorphine that's not precipitated withdrawal, then, considering doing a high dose induction wouldn't be a good idea. But precipitated withdrawal in the past is not a contraindication. So somebody with low tolerance or low dependence, if somebody's using 5 or 10 milligrams of oxycodone a day, or giving them large doses of buprenorphine may not be a good idea. So really understanding what their tolerance is and how long they've been using their particular substance for is all important. And considering each individual situation, like I mentioned, things like altered mental status, acute intoxication, things that don't allow you to discuss the risks and benefits of things would be a contraindication. Somebody's in severe acute pain, or they have trauma or severe medical illness. These are all things to be considered and reasons to maybe not do a high dose buprenorphine induction. And so where can these be done? So it's really flexible in this regard, as long as we're considering the things that I just mentioned. This can be done inpatient, which I do very frequently. It's pretty much almost probably 95% of the inductions that I do in the hospital, I do this way. It's much easier on everybody. It's quicker, more efficient. There isn't, multiple times an hour, assessing for withdrawal and dosing all the time. It's much easier on the nursing staff, and the patients get on their medication much quicker. And it can be done in the outpatient setting, either from the office or at home. And also in the ED, can be done in the ED, but the ED can also provide instruction on how to do this, so the patient can be discharged home with appropriate medication and instructions, and can do these from home as well. So how do we do it? We're going to talk through some methods on how to do this. So the first thing I do always is I give patients the options. I talk to them about the 3 really best known methods of induction, talk about the risks and benefits, and and shared decision making is really important. And like I said, I come across many people, I'm sure everyone here does, who've tried the other methods before and were unsuccessful. So again, having this as a third option, a new option that we can provide, um, is often helpful, especially for people who are kind of scared or apprehensive. So I always talk to everybody about the three methods, and the risks and benefits of each, and try to perform shared decision making with everybody. So I'm going to present to you guys a simplified treatment algorithm that I came up with, but a lot of it's sort of a combination between this from CA Bridge and my own experience doing this. CA Bridge, I've found this is probably the best, most comprehensive guide to doing this. It's meant for the emergency department, but it translates really well into outpatient practice or office-based practice. I won't go through all the nitty gritty on here. I just wanted to show you guys this, and this is readily available if anyone hasn't seen it, but it's a really sort of comprehensive guide to how to do this. And it's something that is done at their facilities regularly. So it is something that is regularly done, and this has been well researched and well written. So, and it covers kind of all the bases. So this is an important resource for anybody. And I'll provide a little bit of a simpler one as well that in a few slides here. And I did give this to Bethany to email out to everybody the simplified treatment algorithm. So if that's helpful for anybody, I will send it out via the email. So I just wanted everyone to see this in particular. So this is the most important part, in my opinion. I talk to patients a lot who don't really know how to properly take their buprenorphine. And if we're talking about a quick, rapid induction, we're talking about needing the buprenorphine to be adequately absorbed into the system, so it's occupying those receptors. You can give somebody 16 milligrams of bupe, but if they swallow half of it, they're not going to. You might as well have given them a low dose. So this is of the utmost importance. Everybody needs to know exactly how to take this, and I walk through this with everybody. Very specifically, and I tell them the importance of this because I need that medicine, all of it, as much of it as possible, to go in quickly and efficiently. Otherwise, it's kind of like doing a low dose induction and people get withdrawal. So I found it to be much more successful when I spend 5 minutes talking to somebody about why this has to happen and how to specifically do it. And that will just right off the top, it'll make this process much more successful. So here's my simplified treatment algorithm, which I'm going to walk through really quickly, and then I anticipated a few questions, and I'm going to answer those, and hopefully it touches all the bases that everyone's considering here. So first of all, we have a patient with opioid use disorder who's appropriate for buprenorphine maintenance. We've gone through all the risks, benefits, and personal considerations. I tend to start with 16 milligrams. Now, take all this with a grain of salt. This is what I tend to do. You can find other algorithms that start with 8, some that start with 12, but I usually start with 16. I've found that to be sort of a good in between. The CA Bridge says 8 to 24. So I've sort of settled on 16 initially, and it's worked pretty well for me. So I give 16 milligrams, and then I reassess in 20 to 30 minutes. And depending on how the patient's feeling, that's where the next part of the decision tree is. So if a patient is feeling worse or they have feeling no better, then I give more buprenorphine. I like to use the CAL score as just sort of what I was trained on, and I just have it kind of memorized. So if somebody, but really we're talking about mild, moderate, severe withdrawal. We all sort of know what that looks like. If somebody gets worse, then typically I'm going to give them another 16 milligrams. And if they look about the same, then I'm going to give them probably another 8 milligrams. So we start with 16, we reassess. I would say a vast majority of the people that I've taken care of with this feel much better on 16. And typically, if I'm going to need to give more, it's maybe another 8 milligrams an hour later or something like that. But a lot of patients do really well on the 16 milligrams initially. Usually without any significant worsening of their withdrawal symptoms. So basically it's give the medication, wait 20 to 30 minutes. If they're feeling worse, I give another 16. If they're feeling the same, I give 8. And then I kind of go back around on this algorithm, reassess another 20, 30 minutes. If they're feeling, and then again, the same. If they're feeling about the same, I consider, do they need another 8? If they're feeling worse, there's the option to give another 16. If once they're feeling better, I typically go with 16 to 24 milligrams as a maintenance dose for most people. So I typically tell them, that's going to be your day 2 dose, 16 to 24 milligrams, depending on the person, their use history. But if they're feeling better after the 16 or whatever it takes going through this algorithm, then we start talking about maintenance dosing and depending on the setting, if you're going to discharge them or see them the next day. So that's sort of how I go about this. And it's fairly simple, fairly straightforward. And like I said, most of the time, the 16 works for me. Maybe 25% of the time, they need an additional 8 to 16 milligrams up front. And then we just start discussing maintenance dosing with them. So a couple of questions that I anticipate people may have is, when do you start, first of all? What happens if the withdrawal doesn't improve? And then what is the maximum dose that somebody can get? So when do you start? So I just like to utilize the patient's prior experience. And what I usually tell people, instead of giving them like a cow score or something to go by, I basically tell them, wait as long as you can wait comfortably, where you get to this place where you're at risk for using again because of the withdrawal symptoms. And that prevents me from having to give people a specific timeline or time frame, because if they fall outside of that, I say wait 12 hours, and 8 hours in, they're really not feeling well. I don't want to box somebody into a certain time frame. So I tell them, wait until you're at a point where your withdrawal symptoms or your cravings are bad enough that it's going to force you to go and use to alleviate those. Then you start this process. So that's been pretty effective, and it sort of allows the patient the control to figure out when to start without boxing them into a certain time frame or a certain COW score. I tried doing the COW score before, but I found people don't really pay attention to it. They weren't filling the thing out. They weren't really following it, and it was just causing a little more confusion. So by allowing them to do the symptom based, I found it to work better. So this is the part of the CAA bridge algorithm about what happens if you get precipitated withdrawal. So I've followed this pretty closely. As I mentioned, if patients aren't doing well after 16 milligrams, I give another 8 to 16 milligrams, as you can see on the algorithm here on the right. The CAA bridge recommends 16 milligrams, waiting 30 minutes. If the symptoms have not improved, then you give another 16 milligrams. And then there are some options for adjuvant medications on the right-hand side. Rarely I've had to use some of these, Zofran, some clonidine, but really the cure or the fix here is more buprenorphine. It's displacing the fentanyl, and it's getting adequate doses of buprenorphine on those receptors, because that's really what's going to fix the problem, not gabapentin or clonidine. Those can provide some mild relief, but whenever I talk to patients about this, I make sure to stress that you shouldn't be replacing buprenorphine with clonidine. You should be following this algorithm and getting proper amounts of buprenorphine on board, instead of diverting your efforts towards these other medications. But they do have their place sometimes, and I have used this, particularly like Zofran and things when people get nauseous. And things like lorazepam or something, I would typically reserve usually more for like the inpatient setting. But like I said, I haven't had a lot of experience. I will talk about one at the end, but I haven't had a lot of experiences where I've needed to use anything other than more buprenorphine. And so question number 3 is, what's the maximum dose? Like, what happens if you keep doing this? What's the maximum dose of buprenorphine? So that I don't have an answer to, because and I haven't been able to find it. I think the most I've ever had somebody take is 8 milligrams in a day. So that's 64 milligrams. According to the CAA bridge algorithm, patients can get up to, if you follow this exactly, up to 80 milligrams. So if they go through 16 on the left and then another 16 30, they say 8 to 24. So the max would be 24 and 24 initially. That's 48. And then if you go through the precipitated withdrawal piece of the algorithm, they can get up to another 32. So I have not had to go that high ever. So the specifics on what's the highest dose, I'm not sure, but I have found most people 4 or 5 8 milligram doses. Up to 8 has been the most I've ever given. Um, and so it's sort of like a trial and error thing, but I think you'll find that most people after, if they do have precipitated withdrawal, another dose or 2 doses of buprenorphine tends to alleviate their symptoms for the most part. And then you can start talking about day 2 maintenance dosing. So going along with that, what's the maximum dose? So I pulled a few studies. There's been some really good studies recently, or some studies showing some pretty good results here with relatively high numbers of patients. A lot of these have been from the emergency department, showing 1.2, 1.6, 0.76 rates of precipitated withdrawal, which is much better than almost any study I've ever seen with the other methods. The issues I have with these studies is that the dosing and method of administration is very inconsistent. So one of these studies, they started people at 2 milligrams, which is like not even really, I wouldn't consider to be a high dose. So I don't know if some of these precipitated withdrawal symptoms are coming from them getting 2 milligrams initially and then being treated again. So there's a lot of inconsistencies in the recent studies in terms of dosing and method of administration. And also monitoring these patients and scoring them for the precipitated withdrawal rates. But I can tell you from my own personal experience doing this quite a few times over the last year, very low rates of any significant precipitated withdrawal. I've never had any. I don't think that have been worse than the worst one I've seen with low dose induction. And they tend to, in my experience, happen a lot less frequently. The important thing to note about these studies is that there were no cases of respiratory depression or anything, no significant adverse events. So even with these high dose inductions, people weren't, becoming sedated and needing to be intubated or admitted to the hospital. There was one case of induced sedation in the study in the middle, but it was somebody who was a non-fentanyl user, but there was no further info. They didn't mention anything about hospitalization or anything like that. They just said induced sedation. So even with these higher numbers of patients from the ED and everything, it looks like it's relatively successful without any reported significant adverse events. And so this is a 2-page handout that I made that I use a lot from, we have a system in the ED where the patients are given a medical screening exam. They're given this, and they are given the medication from the ED to go home with. I also use this from my office. There's a little bit of a difference in the documents, but this is a handout that I've been using for patients who are doing this stuff at home. I am including that in the handouts for everyone as a Word document with all the like main general stuff taken out. So if anybody wants to use this, or it's editable, so you can do whatever you want with it. But I just thought if somebody wanted to use it, you can save some legwork and you can edit it yourself and add whatever you want or take away whatever you want. But it'll be there available for anybody who wants to take a look at it and or use something similar to this. But this is what I've been using from the office and from the ED. So in the interest of time, we're getting towards the end here, but I want to talk about I wanted to go through a case, but I'll go through really quickly. I'm just going to go through case 3 because this was a case of significant precipitated withdrawal. So case 1 was a guy on methadone, 120 milligrams. In the hospital, I induced him on buprenorphine with 16 milligrams and an additional 4 one day after his last dose of methadone without any adverse side effects. Case 2 was a similar thing, except she was a higher dose fentanyl user, and she was about a day or 2 days out from use, and it went very smoothly. Case 3 was a different story. So I'm just going to go to that because I want to give some time for some questions. But so really quickly, this was a case of a 42-year-old male. So he was probably the most significant fentanyl user I've ever met. 10 years of 10 to 20 grams of fentanyl, intranasal fentanyl per day, depending on the potency of the fentanyl. He was buying large amounts, using 10 to 20 grams all day, but he was somebody who started low and kind of worked his way up. But he was a successful guy, owned his own business, lives with his wife who also was using about the same amount of fentanyl, and had no prior treatment history. So he was living in a safe home. He had resources, a phone, transportation, a supportive wife. I discussed all the risks and benefits with him. He wanted to do a high dose induction. I had done one on his wife 2 weeks earlier, and it went really well. So that was also an influence for him. So I'll tell you what happened. He said, this was his quote, was that the first 12 hours were a living hell. The patient, he took one film initially, reported feeling really hot, got nauseous. Over the course of the next several hours, he got nauseous, vomiting, diarrhea, nasal congestion. He had these strange symptoms of sort of almost like hallucination. He said he felt like he was outside of himself, watching himself. He didn't have any SI or HI or any sort of abnormal thought patterns. His wife said it looked like maybe he was responding to some internal stimuli. He was like laying on the bathroom floor, couldn't really get up, and was just sort of having nausea, diarrhea. So the patient's wife said she almost took him to the ED, but didn't. So he took 8 films on the first day, and couldn't rest at all. Said he couldn't get off the bathroom floor, but what he told me was that he had this moment in time where he was there on the bathroom floor and sort of knew he couldn't get to fentanyl even if he wanted to. So although he was struggling with this illness and all these feelings of precipitated withdrawal, he was not really considering going back to use at this point, which was, to him, in his words, was beneficial. So as the days progressed, he was able to get up. He went to the couch. He was able to, he still was having muscle joint aches or pains, nausea, nasal congestion, not really eating, not really drinking. Did take 4 to 5 buprenorphine films on day 2. And then as the days progressed, he started to be able to eat more, drink more, and sort of remained on the dose of 4 8 milligram films a day moving forward from days 4 or 5, and sort of just felt the symptoms kind of relieving and going away after about day 3, day 4, day 5. He started to really get feeling much better, and he remained on the 8 milligrams QID following the acute precipitated withdrawal. And he was, after seeing him in the office following that, he's transitioned to Sublocade, and he's doing great. He hasn't touched fentanyl since. But this was a rough case, and I don't think I've ever met somebody that was using this much fentanyl. And so it was difficult to decide exactly what to do and how to start this guy on buprenorphine. So my sort of thoughts and reflections, risks and benefits. So he was using 10, 15, 20 grams of fentanyl. So like when I'm discussing risk and benefit, it's like what the risk of what he's doing versus the risk of precipitated withdrawal. It seemed that the risk of what he was doing outweighed the risk of the precipitated withdrawal symptoms, the risk of those occurring. But the question is, could we have done this a different way, like low dose or cross taper standard methods? I just don't know. I don't think so. And somebody using that much, he has not been able to go any more than an hour or 2 without using fentanyl. So I didn't see him being somebody who was going to go 3-4 days or however long it takes to get there. And he reported that he wouldn't be able to do that. So I wasn't really sure what other options we had. So how effective was it? Well, he didn't really follow the instructions all that well. He started with a lower dose than I recommended. He didn't utilize any of the adjuvant medications at all. So it was difficult to determine exactly what would happen if he would have taken a higher dose initially, like I instructed him to, versus taking a lower dose. They did deny any respiratory depression or any sedation, any significant sedation. And so the most severe symptoms happened the first night. It was after I'd seen him in the office. So the next morning when I got into the office and I was talking to his wife on the phone, and she told me about the symptoms of sort of this kind of hallucination, those sort of odd symptoms I mentioned, which when I talked to them initially, I said those altered mental status, things like that I would want somebody to go to the emergency room for it to be evaluated. So if I would have talked to them that night and when he was going through this, I would have recommended that they go to the ER, but it's one of the risks of sort of giving patients the autonomy to do this at home. So even though talking through the risks of it and what to do if you experience adverse side effects, sometimes people just don't do that, and they also don't take the medicine exactly as prescribed. So I think there was some issues there with this whole procedure, that it didn't really happen the way it was supposed to happen, and the withdrawal came on, and it was pretty severe. So, but the light at the end of the tunnel here in this case is the patient. After I saw him, a week later, he said that he'll never go through this again. He said he never thought he would ever be able to come off fentanyl, but having the experience that he had, he said if it was easy and it just was a smooth transition, then he would be more likely to consider going back to using fentanyl. But because of what occurred, he said he would never consider it again, ever, and he'll never go back to using. Now, I'm not advocating making somebody suffer to get off fentanyl. That's just sort of how this case played out. And he's, to this day, he's been in recovery for about 3 or 4 months on Sublocade, doing really well. And he said, like I said, the memory of this will prevent him from ever using again. So there's some light at the end of the tunnel, although he did have a pretty significant response to this. And out of all the cases that I've done so far, this was the one where I saw this severe withdrawal. And I think it was in part due to not taking the medicine exactly how it was prescribed, but also it may be due to 10 years of high amounts of fentanyl use every single day. So these are just things to consider when if you have a patient in this sort of scenario. So I know I kind of went right to the end, guys. I'm sorry about that. I can hang out for a few minutes if there's some immediate questions, and I'm happy to converse via email and stuff too.
Thank you so much, Dr. Gallagher. We will keep the questions that are in the chat and I will forward them on to you. So maybe we can answer them via email since we are close to the end. But I think we may have time for one question or a few. Let's see. Let me go. Charles wants to know, when you give 16 milligram initial dose, do you have them dissolve both strips at the same time or one right after the other with a delay after the first strip?
I usually give them 2 at the same time because it's really important initially to just get the dose in right at the same time. So sometimes if I have the availability of tablets, I'll do the tablets. Like in the hospital, I'll do the tablets. From the ED, we were able to get the films put in our Pyxis for take home thing. So when we do that, they get the films, which are just a little less convenient to put under the tongue at once. But it's really important to get that dose in initially right off the bat instead of 8 and then waiting and then giving another 8.
Thank you. Anna wants to know if you're giving straight buprenorphine or doing inductions with buprenorphine naloxone mix.
No, I haven't. I use the bup naloxone mix, and the reason why, for a couple of reasons. One is availability and willingness of insurance to pay for it. I find more likely the buprenorphine the Suboxone product is more likely to be filled than the mono product, but also taking into consideration the mechanism of action, bup has a much higher affinity for those receptors than naloxone. So bup is going to outcompete naloxone. Bup is going to take over those receptors. Naloxone has a bioavailability of like 1% from the mouth. So you're not even really absorbing much naloxone anyways. And all the naloxone that you do absorb is the bup's gonna outcompete the naloxone. So it doesn't really matter either way. In my experience and knowing the parts of the pharmacology that I know, that's why.
Thank you so much, Dr. Gallagher. Since we are over time, we're, like I said, save these questions and we can answer them over email. If you did not submit a question, you can always email me and I can pass it on to Dr. Gallagher and we can try to answer it that way. But thank you so much for joining us this afternoon. Thank you so much, Dr. Gallagher, for this wonderful presentation. I will be sending out the follow-up email with the slides and materials from today. But yes, thank you so much for joining us.
Yeah, thanks.